Okay, just good morning, everyone. We're almost to the end of the academic year. We have our last two grand rounds of the year scheduled, and these we've reserved for the good folks at the PGME office who've been helping Stephanie Kletke and I with the implementation of CBD. So Steph Kletke, if you're not already aware, was a stellar resident in our program who went on to do subspecialty training in pediatric ophthalmology and retinoblastoma, and was recruited back to Sick Kids and has graciously taken on the role of CBD lead for our department. So Steph, thank you for all the efforts that you've been making. We've been working with advisors at the PGME office, in particular Charles, who is currently away, but Lisa Saint Amant has offered to step up and support our department during this time. We are indebted to the support that we receive from them because it is a big deal to be undergoing curriculum change. It's a tremendous amount of work, both for the PGME office, for myself, for Steph Kletke, for our entire competency committee, and for our administrators, such as Sandra, and of course our Vice Chair of Education, Alan. So all of us have been working hard. July 1st is a drop dead deadline for us. You know, our residents in PGY1 are currently in the CBD curriculum, but we don't see much of them because the majority of their time is spent off service. But this cohort is already used to EPAs and the new milestones that they have to achieve. But for the rest of us, for faculty, July 1st represents a start of something new. We have to get used to the new system. We have to get used to the EPAs. We have to get used to Elentra. And I'm hoping that the rounds today and next week provide everyone a solid foundation as we go forward with this new curriculum. We will next week also do a hands-on tutorial on how to use Elentra. So I hope that everyone got the slides that I pre-circulated and is able to access their Elentra account. If you haven't already, take a look at those for next week. Elisa, thank you so much for being with us today. I appreciate all the support from yourself, from Charles, and the entire team at PGME as we embark upon this new curriculum in our program. And the floor is yours.
I'm just going to share my screen. Okay. So I'm just going to introduce my team. I know some of them can't be present today. So Charles Andreasen is the CBD lead for ophthalmology, as Amandeep mentioned. He's a curriculum coordinator at Postgrad. Justin Fletcher is education and curriculum officer, who is also assisting with the development of these sessions. Both are currently away on vacation. Charles and I will lead the June 14th session. And my name is Lisa Saint Amant. I'm the project manager of curriculum at Postgrad. So just to give you a little bit of a run through, I know Amandeep kind of mentioned this in part already, but the first session will focus on a general overview of CBD. Then we'll do a deep dive into how CBD is being implemented for ophthalmology. And then I'll just do a brief overview of the systems that are supporting CBD implementation at Postgrad, but the actual demonstration will take place in part 2. So that's on June 14th. And we'll also have an interactive activity. So we'll have faculty log into Elentra ideally and complete a mock assessment based off of a clinical scenario that you might encounter in your practice. And that'll just be a way for you to, one, get acquainted with the system, but also practice coaching and feedback with EPAs. You know, they are a tool for residents learning, and the goal is to provide coaching and feedback on residents' skill development as they progress through training. So the learning outcomes are to describe key elements of competence by design. So what are the differences between this curriculum and the traditional residency program? To be familiar with the competence continuum, which I'll introduce in a moment. So those are competency stages for which the PGY years fall into. And then to provide you with an overview of entrustable professional activities. So what are they? What are some examples from ophthalmology? And then to introduce you to competence committees. And then the second session, as I mentioned, will provide a thorough overview of Elentra access and some tips for feedback and coaching where you'll actually get to apply those. So before I get started, I know there's audience kind of on Zoom as well as in person. For the in-person, I'm going to ask that you just take a picture of this QR code so that you can fill out this question. So what is one of your burning questions about CBD and CBME? So the reason why I'm posing this question is just because, you know, I've done these types of sessions so many times, and I think it's always beneficial to tailor it for the audience. So I don't want to make assumptions about what, you know, you care about as a faculty group, and I'm happy to answer specific questions that you have with CBD and to kind of tailor it to your needs. So the QR code is up. So if you could just use your phone and take a picture so that you can access the survey. And hopefully this doesn't affect your view of the QR code, but I'm also just going to pop the link in the chat.
Sure, we've got it there. Thank you.
Perfect. Okay. So I'm just going to pull up the poll to see if anybody submitted. Okay, well, I haven't seen a response yet. We'll just give it a few more minutes. Alternatively, if there's a microphone in the room, you're like welcome. I know it's a smaller group, so you're welcome to just kind of voice it if you feel comfortable, but sometimes the poll just allows a little bit of anonymity and we get a little bit more authentic responses.
Lisa, you actually posted it to just hosts and panelists. I'll get that out to everyone if you want to keep going. I'll get your link out. Sorry about that.
Perfect. Yeah. Okay. So let me just move yours. Okay. So I'm going to just give you an overview of CBME. I don't know if all of you are familiar. I know that some of you might have had practice completing EPAs, but for some of you, this might be quite new. So just as a general overview, competence-based medical education is more oriented towards outcomes. So traditional residency is focused on time and training, right? So the idea that by virtue of exposure to a given clinical specialty for a specific point of time, it's assumed that you would gather enough, you know, clinical exposures to different case types. You would have had enough kind of informal observation of your performance. And obviously there's still assessments like IDERS and things like that. But the idea is that by just time exposure to a specialty, you would be expected to eventually get to a point of competence in your given practice. And so CBME is more about having an identification of the specific skills that are required of residents in order to be deemed competent by the time they exit training. And we are being more deliberate about having exposures to that resident's performance and actually documenting feedback. And so there's a lot more data that's produced as a result, as you could imagine. And so we have what are called competence committees, groups of faculty that review resident performance data in order to determine if they're progressing as expected, as well as to promote them from stage to stage and year to year, right? So there's a lot more information, a lot more pixels to create a fulsome picture of how a resident is performing in a program. And so we do expect that we can identify residents in difficulty earlier on in training, which is really important, right? Because then it allows more of an opportunity to address some areas of concern, maybe develop a modified learning plan for the learner, maybe identify if there's another specialty that might be better suited for them. And obviously there's better patient outcomes as a result as well, right? Like that's why we're doing this. That's a big component, is just to meet the societal need and ensure that we're producing doctors that are verified to have the skills that we set out. And so this is just a nice comparison table. I don't expect you to memorize it, and some of it might be above your head just because not all faculty are involved with kind of the curricular mapping of ophthalmology, but just as an overview, EPAs are new, so entrustable professional activities. In the traditional curriculum, it's not to say you didn't have assessments, right? And it's not to say that EPAs are replacing all of the assessments in the traditional curriculum. They're not. Ideally, you would have a robust program of assessment that's inclusive of EPAs, but also still includes IDERs, maybe, multi-source feedback, in-training exams, whatever you, have in your program, just to get a gestalt overview of performance. Training experiences are replacing specialty training requirements and objectives of training. And so these are, they could be clinical, like must get exposure to said off training experience, but they could also be, educational, like they need formal training in the basics of ophthalmology or patient history or things like that, right? So those might be integrated into academic half day. So it's just a list of different educational requirements and exposures to clinical practice. CADMEDS doesn't go away. They're integrated in our competencies. So it's one of 3 standards of CBD is the competencies. So they're integrated in both the EPAs as well as the training experiences. They are grouped by CADMEDS roles. So those are still embedded, although they might not be front facing for you as faculty. As I mentioned before, we still have the end of rotation, and maybe if you have a long rotation, mid rotation assessments. The difference between CBD and the traditional curriculum is we are now, changing the name to assessment, right? It's not an evaluation, it's assessment. And the form itself is shorter. So it's only 2 pages now, as opposed to, an unwieldy amount of key objectives for the rotation. We limit them to 10. There's also a learner handover section that just makes sure that we're keeping tabs on all of the different CADMEDS roles, inclusive of medical expert, but also some of the ones that don't really show up in key objectives, to make sure that if there's any issues in, say, professionalism or, communicator, that's being flagged to be addressed in the next rotation. So that's kind of the main difference between those two. And then the last one is rotation plan. So before there was rotation goals and objectives, these were incorporated into this new document called the rotation plan, which is hyperlinked to the ITAR in Power. And your program might also have, sometimes there's a Quarkus site, or the program director provides it to faculty supervisors, because it could be helpful to understand what the requirements are for a given rotation. It lists out all of the training experiences that are mapped to that rotation, the EPAs that are expected to be completed, any other assessments, and then it lists the key objectives, which are assessed on the IDAR. So that's a really handy document, I think, as a faculty to know where to locate that and that it exists. So I mentioned this before, it's kind of a new way of conceptualizing training, right? We have these competency stages, and it's not to say that PGY levels go away. They're not going away, right? We try to have the post-grad levels for payroll and funding, and I'll show you this once I give you an overview of the curriculum assessment map for ophthalmology. But the stages are overlaying to the PGY years. So PGY 1, residents would be in transition to discipline and foundations. So this is where they receive a basic orientation to the specialty, basically signing off on the skills that they should have been deemed competent in by the time they graduated their MD. Foundations, they begin to develop kind of like the bread and butter of that specialty. By the time they hit PGY 2 to 4, they're focused on more advanced tasks, right? Like they might be given a lot more autonomy, of course, with the oversight of faculty, but they might be able to, complete more of a procedure or manage cases. And then in transition to practice, which is in the final PGY 5 year, we're preparing for independent practice. And so this is a very unique component of CBD, this dedicated time to focus on maybe some of the consultation skills and some of the higher leadership competencies that really make sure that residents are prepared for independent practice once they graduate. And so with this, the Royal College has moved back the exam so that we can have a more fulsome focus on transition of practice. So once residents reach core of discipline, the competence committee would sign off that yes, the residents are fit to write the Royal College exam, and they would write it ideally before transition of practice starts.
Lisa, I'm just going to interrupt you for 1 second. Just to clarify, we're going to starting about 2027, the Royal College exam is going to be moving up a little bit. So it's going to be earlier in the training in the traditional PGY curriculum, and so we do anticipate, as you mentioned, that the residents might be writing it at some point in their PGY 4, early PGY 5, as opposed to late PGY 5 where it is now, and that would allow the transition to practice bit to play out after the examination.
Thanks, Amandeep. So just an orientation to EPAs, what are they? Some people, confuse the EPA with the assessment itself, but EPAs are really a task. So the specialty committee at the national level would have gathered to develop a key list of tasks that are divided into each of these stages, right? So EPAs are stage specific. So the idea that residents would complete, basic orientation tasks and transition of discipline, and then they would move to foundations of discipline where they'd have a whole other set of EPA tasks to complete, and so on and so forth. And so these are really developed, based off of your capability to observe them in clinical practice, with some exceptions, like some EPAs, can be done with a case review or discussion. But the idea is that they're a tool for providing feedback and coaching to learners. There are specific number of attempts that residents require in order to be deemed, entrusted in that EPA. And so a resident would be expected to attempt EPAs early and often, even regardless of whether they're proficient already in that activity. Like ideally, they'd be doing it at the early stage, just so that they can get that feedback and coaching and progress over time. Because ideally, we want to see this like gradual sloping upward curve of achievement. And then they require, a certain maybe number of different case types, or just depending on the EPA, there might be specific contexts that they need to achieve in order to actually be signed off on that EPA. And then entrustment or sign off of an EPA happens at the competence committee level. Your job as a faculty is not to make, some sort of future inference of residents' entrustability in a given EPA. Rather, you're assessing a resident's performance in a specific encounter, and the accumulation of data is going to be used at the competence committee to actually determine, okay, is this resident fit to progress? And so each EPA has a series of milestones. And so these are the subcomponent of the EPA. And I'm just going to use an example. So maybe if you're baking a cake, that could be an EPA, for example, right? It's like more of a high level task. And then the milestones might be, weigh the flour, or, warm up the butter before you mix it, and the different components of those steps that show competence in that general EPA. Those are the milestones. And so when we think about an EPA assessment, it's organized with the milestones as the assessment criteria, and then there's an overall rating to determine whether the resident was deemed competent in that specific EPA encounter. And I'll show the scale in a moment just so you can be oriented to that. So these are examples applicable to, ophthalmology. So some of these were completed in the PGY 1 year with off-service faculty. So in total, there's 30 EPAs over 5 years. So transition of discipline, the first stage, first couple months of PGY 1, there's 2 EPAs. So this is just an example. I'm not going to read through them all, but I think it's, handy for you to have, and maybe you can refer back to the slides after if you're curious. Foundations of discipline, there's 9 EPAs. Okay, and once they complete that, they can move to core. So this is relevant to you because residents will be transitioning into core of discipline. So there's 15 EPAs in total. I think it's helpful to just familiarize yourself with the EPAs because faculty have an important role in engaging in EPA assessment completion. Certainly, and I'll talk about this later, it helps to prevent residents from cherry picking cases. And if the goal is to get good feedback and coaching on EPAs, and I think faculty initiating these assessments is really helpful in that regard. So this is just the EPAs 9 to 15. And you'll see that some of them, are not necessarily like workplace-based assessments. So we have conducting scholarly work, delivering scholarly teaching. So that's just something to keep in mind as well. And then transition to practice occurs in the last year of training. And as I mentioned before, it's, more leadership, higher level leadership skills and competencies. So running an outpatient clinic as opposed to maybe, attending to cases on the clinic. And so I mentioned this before, this is the curriculum and assessment map, and this is PGY1, right? So the residents would have rotated through all of the off-service rotations. This shows the EPAs that are mapped to each of those rotations. Granted, this is probably looks like, some foreign language to you, but it's just the one letter acronym for the stages. So F is foundations, and then this is just the sequence correlating to the numbers of the EPAs I showed you in the previous slides. But you'll see that there's still, IDA requirements for each rotation. They still have to do their written exam. And then you can also see, remember I mentioned the competence committee who meets to determine resident progress. And so they have regular meetings throughout the year just to review the data and sign off that, yes, okay, the resident in completing all of these requirements did, pass, and we can advance them to the next stage. And so this is PGY2, more relevant to you as you'll be completing the bulk of these EPAs. So in block 1, they begin in general ophthalmology, and there's still some foundations EPAs that they might be able to complete, and then they'll move into core as of block 4. So we have this competence committee meeting taking place in the late summer just to sign off on progress. And so that's something to keep in mind because the priority for the first 3 months of the next academic year will be to get to kind of complete their foundations EPA requirements. And so that's just something you can kind of focus on in your clinics. And then, starting in the fall, we can move into core. Residents are able to work ahead. So if a resident requests a core of discipline EPA, like for sure, like granted, they can work ahead, and that's the whole idea of not being such a time-based system, but they still need to prioritize those EPAs that are required for the stage that they're currently in. I'm just going to pause to see if there's any questions.
No, there's one question in the chat that you've already addressed, Lisa, so thank you.
Okay, perfect.
Lisa, I have a question.
Yeah.
Actually, 2 questions, and they're related. So this is a major paradigm shift in evaluations of our trainees. Is there evidence what precipitated this? Like, what was wrong with the previous? Just so we understand how we are morphing into this new system. And also related to this question, one of the concerns I hear from the resident body is that they're going to be evaluated all the time. Could you maybe address those issues?
For sure. And I mean, and this has been a kind of topic of conversation like across the country, and we're currently in the middle of doing like a second iteration of CBD, the communications of which will be disseminated to all program directors maybe towards the end of June from the Royal College. And so it is an iterative approach, right? We're constantly doing program evaluation to make sure that there's added value for programs, right? That this isn't just an administrative exercise. But what precipitated this is, and it's going to be variable across specialties, right? The culture is different from ophthalmology compared to, general surgery. But we were finding in, some training programs that residents could go through all years of training and not be directly observed from start to finish in a specific like clinical procedure or a scenario with a patient, which, you know, is arguably, it could be problematic. You know, there's other ways that, you know, we've been able to identify residents that are kind of unsafe or, you know, patient error kind of situations. And obviously you have other healthcare professionals who can assist with that. You also have fellows, right, which, you know, really help with assessment and things like that. But the idea was to make sure that there's greater exposure to residents' performance in the clinical environment. And this is really to meet a societal need too, to kind of verify that, you know, especially as training is, you know, training practices are changing all the time, right? We live in an information era, and there are changes in practice, and the EPAs just kind of help to re-solidify the important skills that residents need to have and to actually be able to demonstrate that that's happening in the clinical practice, right? What's set out in the curriculum and assessment program is different from what's happening on the ground, right? We have hidden curriculum, things like that. So this just makes sure that we're kind of being accountable to the public. That's one. Two, it's meant to benefit learners. And I think initially when when CBD was rolled out, the kind of idea of EPAs as being for residents learning and more of a formative assessment got lost, right? And so, you know, part of that is probably because there's, you know, targets associated with the EPA's completion. Part of it is related to specialties right out the gate. Like when it was a new initiative, there was a lot, maybe too high of a volume of EPA requirements. It's not the case for specialties now, right? We've parsed them down. We've learned from those experiences. But certainly, you know, for the first cohorts, the first two programs that launched, it was an exceptional assessment burden. And so, you know, those programs were unfortunately at the bleeding edge of innovation, and we had to kind of learn, you know, to kind of match this theoretical model with something that's more feasible for, you know, practice. But really the idea is, you know, in addressing the kind of concern of residents, like I think that's really one of the purposes of this faculty development session, is to emphasize that this is really supposed to be a vehicle for feedback and coaching. It's not supposed to be summative. And I think there's been misconceptions, and you know, it's hard to kind of keep a tab on all of the faculty and residents and kind of you know, dispel some of that. But really, you know, the idea is that some programs, like even, you know, might have targets for attempts and not focus so much on entrustments, or maybe, you know, might adjust like the total numbers, which we have the local flexibility to do. But I think the more that faculty get engaged, especially, the less residents will feel kind of the strain of initiating them and feeling like this is more of an administrative exercise, right? Like part of that is reliant upon faculty engagement and buy-in, right? To be like, hey, at the beginning of a clinical, or maybe the beginning of a shift, to say, let's pick out a case where I'm going to observe you today and I'm going to give you feedback. I think if that was the approach, then residents, you know, would see more value versus residents kind of seeing their dashboard, faculty being like a little hesitant to complete EPAs, and then feeling the pressure of having to ask faculty all the time, oh, can you complete this EPA? I need to meet my targets, et cetera, et cetera. So it's a culture change. And I think as you progress through CBD, just keep note of some of the pinch points, whether that be structural, systemic, or, you know, with engagement needs for faculty development, and then we can troubleshoot. Like it really is an iterative process, and we don't want this to become like a make work activity and it to not have value for your program. You know, it's a long-winded answer, but I hope that it kind of provides a little bit of a context and even beyond ophthalmology.
I also think putting the emphasis on the coaching as well as the evaluation, probably it makes it more of a learning experience for the residents, and helping them to achieve their goals rather than just to constantly be evaluated on these goals.
Yeah, absolutely. I had a session with a program of pain medicine 2 weeks ago, and they're a little bit further along in implementation, and we're just kind of trying to sort out ways to kind of increase in faculty engagement, but also kind of focus on the feedback and coaching element. And one of the suggestions that they had was, maybe assigning a specific EPA to a faculty so that they become the expert of that EPA. They can take ownership of it. They'll have like more rich feedback just by virtue of, always doing that kind of observation for residents and kind of picking up maybe on some of the nuances in performance. So there's different strategies that you can use that will like help to provide more of a like richer feedbacks. We know that like faculty are also overburdened too, right? So how do we make this easier for them? Like, I'm sure that they also want to, they're in teaching and academia, they also want to be able to like provide a rich experience. And so how do we kind of facilitate that? And part of it could be assigning EPAs. Part of it can just be like making this a routine encounter. It doesn't take long to complete an EPA in Elentra. It's about 2 minutes on average when we look at the data. So I think just like, again, that cultural change of like, one, being able to access the system, maybe having like QR codes in like the clinical environment, and then just making it a habit of just completing these on the regular and not thinking so much about like the targets, right? I think that can kind of create a tension with learners and faculty. I won't spend too much time on the other years of training, because I know that this isn't going to be something that you're focusing on for July 1, but I mean, it is helpful to just know that like the general mapping of these EPAs across the year. So core of discipline continues into PGY3. It's quite a long stage, right? So they have a lot of opportunity to complete these EPAs. And then it continues into PGY4 as well. Different rotations, of course. And then PGY5 is solely focused on transition and practice. And as Amandeep mentioned, the exam is to be moved to the PGY4 year by the time that this cohort moves into this stage. Okay, and so this is along the lines of what we've kind of been talking about in some of Dr. Slamovic's questions. So it's maybe a helpful kind of opportunity to, reiterate some of the points. So EPAs, one, are stage specific, right? So I mentioned that before. They're developmentally sequenced. And so the idea is that, maybe at the beginning of this stage, a resident isn't going to be totally competent in an EPA, but by the time they by the time they move to the next stage, they should be, right? Because it is linked to their stage of training. Sometimes we hear faculty say, oh, how can I entrust a resident when they're like just starting PGY1? Well, the idea is that the actual skills that are mapped to that stage are kind of developmentally sequenced. EPAs are to be attempted early and not often. So this is something that I mentioned, right? And can kind of, I think one of the benchmarks that programs have found helpful is to maybe complete 1 to 2 EPAs per resident per week. And that, residents are communicated the same thing. So just keeping in mind, to complete these, maybe you can focus on like 1 or 2 EPAs in a given stage and just become familiar with them so that it's always top of mind. If a case comes up, you can immediately identify, hey, this is a good opportunity to complete X EPA. That could be a nice strategy. And as I mentioned, you're not actually entrusting residents in that EPA. That's determined at the competence committee level. And the competence committee isn't necessarily being like, oh, we require 5 successful transition discipline 1 EPAs and they only have 4, like we're going to hold them back. That's not the case, right? Like they're also triangulating other data. Maybe there's a reason why they didn't complete that 5th EPA. Maybe like they have all of the EPA requirements, it's just a specific context is missing, but they've manage to get exposure to that in another EPA. And so there is flexibility in terms of sign off. So it's not kind of this hard baked rule either. And this is the scale that I mentioned. So from the assessor's point of view, this is kind of the overall rating that you would be providing to residents in completing the EPA. So entrustment or successful achievement, we try to move away from entrustment, since again that happens at the competence committee level, but the achievement of an EPA is dependent on either a competent or proficient rating. And so it's not saying that like, oh, this resident didn't need any coaching, like I basically was totally hands off. It's really saying that you didn't need to act for safety and minimal competence. Proficient is just to kind of separate, you know, the difference from competent and someone who's excelling and, you know, merits like some sort of recognition. And maybe they, you know, it's possible that a resident completes their EPAs early and they might be given more opportunities for educational enrichment. So it's just a way for us to identify those high performing residents. And so I mentioned this before. It's something that's, you know, we're continually trying to dispel, like on the ground, is that EPAs are meant to be assessment of learning, right? So, for learning. So it's more formative, and we're really trying to use it as a vehicle for feedback and coaching. Not to say, you know, it's not to replace verbal feedback. We understand that some faculty, you know, prefer to give verbal feedback. You know, maybe like there's some things that you can't really, or you don't feel comfortable capturing on the EPA form. It's not to say like, oh, we want like this verbatim, like transcript of everything you thought about the resident for this given EPA, but certainly certain pearls that the resident can take away from that EPA are helpful, just because it is real time. They will receive the EPA assessment as soon as it's completed, which again, just kind of furthers their ability to take ownership of their learning. And so we'll talk about this next week, but Elentra is the platform that EPAs are completed on. So we'll show you, you know, access as well as, you know, what the learner sees. So the learner is actually able to track their performance. It actually kind of aggregates their EPA completion against the targets that are set for that EPA, so they will know, you know, how many are outstanding and that sort of thing. Programs also have a dashboard to review all of that information, as well as do some comparative analytics between residents and do a deeper dive of a resident, including like qualitative data, which is really helpful. The other thing to note is that EPAs expire after 14 days. And the real reason for this is, you know, after 2 days of passing an encounter with the resident, it's going to be really hard, and the literature shows this, to remember kind of the salient details of that case, right? And so the quality of feedback is going to start to decline. And so there are, you know, there is the ability in the system for program admins and our team to extend it for another 7 days. And that might be, you know, an extenuating circumstance. But really, we want to make sure that these are completed as close to the encounter as possible. Yeah, like the incomplete assessments will show on your dashboard, so you always have track of it. You'll get email notifications whenever an EPA is submitted or completed. And so, you know, there's also the opportunity to maybe do like we're deliberating on doing a weekly digest that kind of summarizes outstanding tasks and like is distributed to faculty like once per week. But really the goal is to get it completed in this window. And honestly, 80% of assessments are done within 2 days anyways. It's really just to curtail some of the assessments that we used to get like 2 months, 4 months from the point of encounter, which is kind of crazy, right? So that's just the purpose of the expiry.
Lisa, can you remind us, in terms of initiating the EPA, is it the learner, is it the instructor, is it either?
Both have the ability to initiate an assessment, providing that they have an Elentra account. Yeah, which all university appointed faculty will have one. Yeah.
And the other point I think is very valid. I think there's going to be a real value in completing these in a timely fashion. Ideally, even at the end of the clinic if possible, and that'll allow for both timely feedback and to avoid clogging people's inboxes, I think. And as you alluded to earlier, the average evaluation takes less than 2 minutes to complete. So hopefully the burden is not too high and we're able to sort of knock these things out in a timely fashion.
I just wanted to show some sample kind of strategies that faculty themselves have provided on how to best integrate EPA assessments into the clinical workflow. And I understand like every specialty is different, right? So ophthalmology, like you might have a different caseload or different opportunities between patients to kind of complete these. So you'll have to kind of really think about how this might apply to your specialty, but it could be helpful. So this is from our 2021-22 survey of CBME faculty. Most people said that it was beneficial to complete at the end of the day. And so that's probably just, art of the feasible. Maybe they have a high caseload. And so just reserving maybe 10 minutes at the end of each day to complete assessments on the observations that you viewed, it could be helpful. Some are cognizant of the timelines or deadlines for a given rotation. I would also throw in, stage, because remember I showed you the different competence committee meeting dates. So residents do have, benchmarks for when EPAs are to be completed. So being cognizant of that, especially as a faculty supervisor, could be helpful, right? To kind of just keep track and make sure residents aren't falling behind. Some faculty organize the clinical flow to include EPAs, and so that's more intentional, right? And I'd argue is of greater benefit to the learner to say, at the beginning of maybe the day, like I'm going to complete an EPA on you, and so you're going into the activity knowing that you're looking for like strengths, areas for improvement in a given performance. And then, whether or not it's done, like the EPA assessment itself is done at the end of that encounter, at the end of the day is like, that's, just depending on time. But I think, being thoughtful about maybe having 5 minutes reserved throughout the day to observe is really, really helpful for managing your workload as well as the residents' anxiety about EPA completion. And this is kind of referring to the EPA assignment that I mentioned. So some programs, assign EPAs, like 1 to 2 EPAs to a faculty, and this might be based off of like the rotation that they're in, the learners that they see, and the stages that the learners are in. So that could be, a helpful strategy, especially for rotations where, maybe a specific site has specific like patients that rotate through that lend themselves well to the completion of a specific EPA, and so that would be of high focus, and so maybe you would designate that EPA to that faculty. And then the other one, so less reported on a focus on responding to timelines of the competence committees. I mentioned that, and complete at the beginning of the day. So these are some just kind of helpful kind of tips to get you thinking through EPA completion. It doesn't have to be necessarily at the bedside, right? Like you can also think of morning rounds, because some EPAs might be appropriate to do via like a discussion. There's also EPAs that are relevant to like teaching or presentation or scholarly work. There's also EPAs that can be done via handover. And then, also just to say, like, faculty have to complete at least 50% of the EPA assessments and hopefully more. But residents are also free to ask fellows and other healthcare professionals as well. We do upload all fellows into Elentra by default, so they do have accounts. But even so, like if a resident initiates an assessment, like they don't necessarily have to have an account to complete it. We can add them as an external assessor as needed. But just to say, like, there's other ways that EPAs are going to be completed as well. mark cases at the beginning of the shift. So I mentioned plan for assessment documentation. So again, 2 to 5 minutes in between patients or end of shift is kind of a good approach. I just want to spend a little bit of time to address this, just because we see that, and this is probably by virtue of EPA assessments being largely resident initiated in the past, which is why we're trying to, up faculty engagement a bit more. We do see high entrustment rates, and that kind of takes away the value of EPAs as a formative assessment, right? And some, reasons why this might happen, again, with residents initiating assessments, it's possible that there's cherry picking of cases, right? There's a big fear of failure culture in medicine, which I'm sure you're familiar with. And so, maybe not wanting faculty to see their deficiencies, maybe I'm conceptualizing EPAs as being more higher stakes. They might, only ask for EPA assessments when they feel like they're competent, or they might choose scenarios that are maybe less complex. And so for that reason, there could be a high entrustment rate. We can also see, a tick box or administrative approach to EPA completion, right? Especially in the programs with higher EPA volumes, it's not so much an issue in your program, but certainly, with those two programs that I mentioned who launched in 2017, the amount of assessments required was untenable. So I'd imagine, it was seen as more so something you just kind of have to click off. So these are things to be aware of, because they do have an impact, right? They impact learning and growth. Again, it's just kind of perpetuating this culture of failing to fail, which, is not only detrimental for the learner, but also when they enter continuing practice, it's not a good practice to kind of hide, areas of weakness. I think it's important to promote a growth culture, and that doesn't only, stem from EPA completion, but also in maybe valuing effort, and the small kind of growth and improvement, and that's like language and part of the hidden curriculum. It also impacts the competence committee's ability to discern resident progress over time, right? It could kind of shield some EPAs that are problematic, that maybe need revision at the national level, and competence committees have to rely more on the narrative data, which is great, but it's also kind of an added workload, right? To kind of identify, yes, they're saying that they're a 5, but when we look at the qualitative data, there's some areas for concern. And so we just want, there needs to be more of a matching of the quantitative to the qualitative data, so that competence committees can provide direction as needed. So this is something to kind of keep in mind, and one of the reasons why we, in the initial EPA scale that we had, there was a line indicating the ratings that were associated with entrustment and non-entrustment, or achieved and not achieved. So we removed that just to hopefully ground faculty in the actual language of the scale itself. So there's been some changes that, we're trying to kind of do in a systems-wide level to kind of encourage more use of the scale. So I'm going to pause one to see if there's questions, but also, again, if you have your phone and don't mind completing this poll, I will have to activate this separately, so just give me a moment.
Lisa, as you do that, there is a question, and maybe Steph, you can address this. Question from Nupra. There's potentially multiple EPAs that might be relevant to a single clinic. So how many EPAs would a faculty member be expected to cover in a particular day? Or is there a specific EPA assigned to a particular clinic? And Lisa sort of addressed that already.
Yeah, and it's going to be a program by program. They might have different approaches to it. So I don't know if it's something that ophthalmology wants to consider kind of assigning it, and part of it just is if that makes sense, in terms of work volume for the different faculty, and how much exposure the different faculty have to the full resident cohort. But yeah, I think that just varies. You yourself can like make yourself abreast of a selection of EPAs, and just kind of take it upon yourself to initiate assessments for those EPAs, and that, you know, is beneficial regardless of kind of the setup of the program, because it's just going to make it more likely that you're going to initiate the EPAs if you're cognizant or familiar with a select few of them. But obviously you can still be open to residents requesting assessments for other EPAs. It's not like you just turn down any other requests from residents, right? But I think as a general approach, it could be helpful for you to just streamline it and be like, oh, you know what, these are cases that regularly occur on my clinic that I want to focus on and initiate assessments for, so that you can kind of do that as an individual as well.
Thanks, Lisa. We will distribute a PDF of the EPA so that everyone can become familiar with them. As of right now, we haven't assigned EPAs to a particular clinic. That might be more relevant later on in PGY3 when residents are in the core of discipline, where, for instance, an anterior segment laser would be relevant to a cornea clinic or other one. So we'll think about that moving forward. But as of right now, they can complete any EPA in any clinic. Multiple might be relevant.
And another point I'll make just for our faculty is, you know, I was part of the specialty committee that came up with these EPAs. And one of the things we tried to do is limit just the total number of EPAs that are required. As Lisa alluded to, some earlier specialties, you know, had 100 or more EPAs, and it was thought that that was the wrong way to go. And the specialties that came on later, such as ourselves, we did try to limit it. Now, you know, it's not just the procedure itself, because I can, you know, there's concern that residents may wish to seek out procedures only, but it's everything that goes into the procedure. So, for example, you know, with anterior segment lasers, it would be the history, the physical examination, the gonioscopy, and then the performance of the actual procedure, and the post-op or post-laser care, you know, the repeat gonio, the repeat visit, etc. So it's a totality of the diagnosis as opposed to just this an actual procedure that would allow the resident to meet the EPA. So it is intentionally a little bit less specific to allow us to have less EPAs. But the idea is not just that someone's performing a cataract extraction or an intravitreal injection, but rather understands the totality of what that means for the patient. Now, Lisa, I'm getting a comment that the link doesn't work, but people are free to use our chat here as well if they have any comments or questions. I'm not seeing much in there. We will have a second round next week. I will encourage everyone to check their email. We did circulate a slide deck that indicates how you can access your Elentra account if you haven't already. I do hope that everyone is able to access that prior to next week, as we are hoping to do a hands-on demonstration where each of you can do an evaluation on your device so that it's easier for you come July 1st. Lisa, thank you for pulling that up. So there's some information there. We've also pre-circulated this as well, but I will ask everyone to try to log into this ahead of time. I don't have any more questions or comments in the chat. Lisa or Steph, do you have any other thoughts?
No, I guess, yeah, this will be covered. Oh, my cursor just went away. Interesting. Yeah, this will be covered. I just wanted to mention, you know, like as a little primer for the next session, the two systems that we're using, and Elentra is not just EPAs. We also have a on-demand learner assessment of clinical teachers form, in addition to the one in Power, which is, you know, more to be used for end of rotation, but they do have the opportunity to kind of submit feedback, not just on faculty, but also other learners as well. And so we'll provide kind of a primer in this session. Again, like as Amandeep mentioned, if you try to log in and, you know, maybe you're having issues, you can't remember either user ID and password, you can reach out to us, and the contact information will be in the follow-up slide, or sorry, in the slides that we send in follow-up. So you can just reach out before June 14th, and that way you can follow along with the case scenario.
Amandeep, I have a question. based on
Yes,
what
go
you
ahead, Alan.
mentioned. I think it's good that, you know, every entrustable act has several components. Taking, for example, cataract surgery, you know, being able to discuss the alternatives, risks, and benefits, understanding what the options are, being able to do biometry, carrying out the procedure, doing the post-op, etc. It has a lot of components. If a resident shows competence in some of these and not in others, do they have do they have to do everything over, or can they just sort of try to show that their competence at a later point after they've worked on their skills in that specific task related to that entrustable professional activity? Is that clear?
Yeah. So I think, Alan, to answer your question, like let's use an example of cataract surgery. You may have a resident with you in the OR that day who has demonstrated an ability, you know, to effectively perform cataract surgery. Now, you haven't seen this resident work up those patients or see them post-op, but I think there's still an opportunity to complete an evaluation there. And it's the competency committee at the end that's going to deem the resident competent in this particular EPA. And it won't be based on a single evaluation, but you know, the resident may submit other EPAs where, you know, they've worked up patients for cataract surgery or they've seen post-op for cataract surgery, and that'll complete the totality of it. So I do think there's still value in completing an EPA for part of a, you know, part of a procedure, because it'll be multiple assessments before we sign off on them.
Okay, good. Thank you.
There is a comment here from Carla as well. This is just a technical issue. For those of you who haven't tried to log into your UofT account recently, the university did move to two-factor authentication. So you will have to download an app called Duo Mobile. But when you, I think it's pretty self-explanatory when you go through that process. I had to do that recently. So just so you guys know, take some time over the next week and log into your UofT accounts, log into your Elentra, so it's a little smoother for us next week. We don't have any further comments or questions, it looks like. I do want to thank Lisa for the time and dedication to our department. I think this is going to be a big change for us, but we are well supported at the PGME level. I do again want to acknowledge Steph Kletke, who has been our fearless CBD lead. I do think we are very fortunate as a program to have Stephanie in this position. She's been very dedicated and working very hard. So Steph, thank you for all the work that you put in to get us to this stage. And July 1st is our big launch. And finally, to the faculty who joined today, I do thank you. I think having everybody at a certain foundation is going to make the transition just smoother for all of us. And I hope to see many of you or all of you next week for the second session in this series. And that'll be the last grand rounds of the year. So enjoy your weekend, everyone. We'll see you next week.
Thank you. Bye.
Bye. Thank you, Lisa.